Hi, Dr. Amit. Hello, am I audible?
Yes, you're
Yes.
audible to me. You're audible to
Yeah.
me. I'm just setting
Hi,
myself up.
hi. Yes. Hmm.
Am I audible clearly, Hetvi?
Yes, Dr. Amit, you're audible well.
So Atib and Sanjay have joined. Hi.
Yes, we're done with our tech checks as well.
Wonderful. Wonderful. Hi,
Hi, sir.
Atib.
How are you?
Very good to see you.
Hi, Amit.
Hi, Sanjay. Thanks for joining in.
No, thanks for the invite.
So this is going to be very interesting. We thought that, both of you are entrepreneurs and the community should hear about, how to get started with this entrepreneurship. And a lot of people actually wrote to me that it's a very relevant topic. Many people are trying to get started and they don't know where to start. And we thought that, you guys could touch base on that for the community members. So really appreciate, thanks for doing this.
Thank you.
Also, Amit, so, I recently started this thing, so earlier let's say for building AI agents, we used to hire data science, obviously, interns, or you can say, junior to mid-level. But now we just pivoted, and what I've done is, I'm straight away hiring our UG doctors, and the level of data scraping, or you can say the knowledge graph they are building, it's 40x way better than any data science guy could do. All I did was, I kind of trained them straight 3 days how to build a knowledge graph in Neo4j or
Wonderful. That's wonderful.
Yeah.
They say doctors who can code are comparatively much better than data scientists who can code in the healthcare point of view.
So now I'm going to double down into it. If in case, if you want to do that, I'm open for it.
Atib, if you can find me some doctors like that who are interested, let me know. If I'm in Bangalore.
अरे भाई इसीलिए तो community बनाया है. We have a huge strength of undergraduate doctors.
I'm looking at someone, hiring. If I can find me 2-3 people, amazing.
Yes, sir. So actually, even I gave them a big story. That's how it was. Yeah.
So we are actually encouraging this entrepreneurship even amongst our colleagues. Yes, we will do that, Aishwarya. We're going to do that, of course. And but most importantly, I see a different kind of a zeal in the undergraduate students these days. And even in our Doctors AI, we have a huge number of students who are connected with us. And they're all active towards doing research on AI, getting started somewhere. I'll get you some guys, Sanjay, don't worry. Some undergraduates, and they would love to work with you. They would love to do research with you. And they have a fantastic appetite for adopting this technology.
Yeah.
And I get this feeling when I'm doing the primers. Just recently, Aishwarya and myself, we did a primer in Nagpur Medical College, NKP Salve Medical College. And Everybody's so enthusiastic about it. And sometimes, our faculties are getting FOMO. They're getting like, I might just miss out. So I better get myself up to date with these, or these students will go ahead of me. So that's the kind of thing. So it's amazing, these technologies. It's getting everyone to know.
So yeah, and so just adding to it, one shift which I've seen is even the undergrads want to go with proteomics, multiomics with the new gen molecules, let's say the NNMs, the NADs, and sirtuins and things like that. So that combined with the tech is a very deadly combination.
Definitely.
I think we'll go live in a minute. So we will keep posted.
So you do it this way, Asparia. You introduce the topic, the speakers. I will come in with just a 1 minute of introduction to why we have kept this topic, and then we go as per schedule. So Sanjay speaks first and then Atik. That's how we do it.
Recording in progress.
Yeah.
Okay, great. And then you come back with the question answers at the end.
Yeah. So we'll go with both the speakers first and the question answers, a 20-minute session where you can also pitch in with like your ideas and stuff.
So Hetvi, give us a cue when to start.
Good evening, everyone. I am Dr. Aishwarya Sharma. Before we begin today's session, I want to take a moment to acknowledge the tragic incident involving the Air India plane crash in the vicinity of BJ Medical College. Our hearts go out to the passengers affected and the medical community, the intern doctors, the medical students who are departed and who were injured while simply going about their day. It's a sobering reminder of how unpredictable the lives are. On behalf of all of us at Doctors AI, we send strength, solidarity, and prayers for all the recovering, the people impacted, the departed, their friends and family. We are very sorry for your losses. Good evening once again, and welcome to another edition of MedAI Web Hour. For those joining us for the first time, these web hours are a part of an ongoing series where we meet every second Thursday to explore the science and technology shaping the future of medicine. But today we are adding a new dimension to the mix, the entrepreneurship. So these sessions are more than just webinars. They are the building blocks for something bigger. They are a prelude to Doctors AI Global Summit, happening on 15th and 16th of November in Bangalore, a gathering of clinicians, coders, creators who believe that the future of healthcare must be doctor-led. And yes, the early bird registrations are open for this event. Now to today's theme, AI Doctorpreneurship, transforming clinical practice gaps into scalable healthcare solutions. This session is for every doctor who once spotted a clinical pain point and thought, maybe there's a better way to do this. So this session is for every doctor. And we are thrilled to be joined by two such doctors who have turned that thought into action. Dr. Sanjay Sharma and Dr. Ateep Sheikh. And our session is chaired by a brilliant and ever-encouraging Dr. Amit Kumar Dey, whose leadership continues to energize the Doctors AI movement. So whether you're building, you are brainstorming, or you're just beginning to explore, I welcome you all, and let's get started. Dr. Amit sir, will start with 2 cents of why you think doctorpreneurship is such an important topic to be discussed.
So thank you so much, Aishwarya. A warm welcome to Sanjay, Atip for joining us at the MedAI Web Hour. And a very warm welcome to all our viewers, all our members of the Indian College of Artificial Intelligence in Medicine, and all the community members of Doctors AI who are joined with us and who are going to be watching this episode even later as a delayed telecast or delayed as a part of the podcast. So it's very important for us clinicians to understand that the sphere of medicine is changing, and it's changing quite rapidly with the intersection of technology coming in to the field of evidence-based medicine. When we started Doctors AI 2 years back, doctors started asking us these important questions, that what is it exactly we need to understand and learn about this technology. We've come quite a way now. A lot of our friends understand this technology. They have started doing courses. They've started being part of our workshops. We ourselves started some courses, and some of our doctors are also now acting as advocates, as leaders, as advisors to companies who are also developing AI solutions as a part of the health tech ecosystem. But beyond that, every doctor has a dream of becoming an entrepreneur. And every doctor wants to become an entrepreneur in their level of clinician. But now, with the intersection of technology and medicine coming in, health tech is always going to be there at every aspect of your clinical practice. It's not easy. It's not easy to be a practitioner as well as an entrepreneur. And it's very difficult when you're dealing with technology solutions and you're trying to build and address some need gap. Why doctors need to lead this revolution is very, very important, because as an individual, as a clinician in the front line, only a frontline healthcare worker understands the need gap that is in front of them. And the vision, the lens through which he sees is something which is going to set the standards in which the technology will be developed over the period of time. So with the right collaboration with a tech partner, a doctor can actually develop a good solution, a tech solution, an AI solution that will help them address the need gap in his or her practice. But in the real world, just doing the research is not enough. Getting your research patented and then developing a solution that is scalable and, more importantly, that is sustainable is so very important. So this is why we thought that this time in the MedAI Web Hour, we're going to invite two very important individuals, two gentlemen who has actually made this possible. They have built a solution, they have patented, they have got their research established, and now they're into the foot setting of getting themselves into a stable business model which can help them scale and sustain their model, not just to serve the community, but also to help develop this healthcare ecosystem. So with this introduction, I would now request Aishwarya, you can take over, you can introduce both our speakers. We would love to hear about their venture, how they started their journey, and how they came to building up this solution, what inspired them, and then we can take up some questions at the end of both the talks.
Thank you so much, sir, for that input. This is my true honor and privilege to introduce to you our first speaker, Dr. Sanjay Sharma, MedSynapse community. If you can just help me with the CV slide. Yeah, thank you. Yes. To introduce Dr. Sanjay sir, he's a podiatric surgeon and a wound care specialist. 11 years of being a podiatric surgeon with the lowest number of amputation rates in DFU patients, independent study done by a pharma giant. He holds a blend of qualifications in management, artificial intelligence, and health economics from IIM Bangalore, Public Health Foundation of India, Bangalore, and World Bank, respectively. He's an entrepreneur with successful exits in 2 companies and presently investee in 4 companies. He's a mentor and advisor for the medtech startups through NSR-CEL, Stanford SEAL, and GenServe. He's an investor with 7 international patents in medtech and telemedicine, 119 paper presentations, guest speaker, and publications. He's felicitated as the Rising Star in the Times Healthcare Achievers Award, instituted by the Times Group and the Government of Karnataka in 2019. In 2022, he was awarded as the Best Podiatric Surgeon in Karnataka in Times Group. Food Secure was also awarded as the Best Podiatric Clinic Chain by India. I welcome Dr. Sanjay Sharma, sir, and we are very eager to listen to you talk. Thank you.
Thank you very much, Dr. Aishwarya. Thank you, Amit. This has been a brilliant forum in terms of where we talk about technology integrating with medicine, and especially doctors being a part of it, which is the need of the other. We have been during I would say the previous era where we were talking about telemedicine. Most of the telemedicine was driven by the engineers, and we doctors followed suit. In terms of telemedicine, we adjusted to the technology but now the time has come where we drive the technology the way the clinicians want it, rather than the engineers driving the technology as they would find it right. With this, let me share the screens and then take it from there. Are my screens visible?
Yes, sir.
Okay. So I don't know, many of you, when I completed my super specialization and came back to India, I introduced myself as a podiatric surgeon, and most of my classmates themselves got confused and started sending me kits for various surgical interventions. And when I asked them, why are you sending me kits? And they said, okay, you're a pediatric surgeon. And I thought when you introduced, you misspelt it or mispronounced it, saying it podiatric surgeon. So a podiatric surgery is something which deals with foot and ankle. And why it is important today is the prevailing problem that you see on the screen. Every 20 seconds, a limb is lost due to diabetes. And in India itself, there are 140,000 amputations, major amputations that happen annually, and about 14 lakh major and minor amputations that happen annually. And it is not just having amputations. There is the 5-year mortality is 70% in the diabetic foot amputees, which is higher than the cancer mortality. You can see here in the global mortality rates, which has been shown here, only the lung cancer has the mortality rate higher than the diabetic foot amputations. But 80% of these amputations can be prevented with various podiatric interventions that we see. And here what comes the next problem that I'm seeing here. I get these kind of messages on WhatsApps every now and then, and asking me what we should do. And this is where the journey began in terms of how can the Indian physicians here can address these kind of issues, which are usually not treated very well, because we are not trained, at least in our generation, we were not trained on how to treat a diabetic foot. And even today, a diabetic foot ulcer or a diabetic foot condition is kind of a taboo amongst the surgeons also. They think if you're doing diabetic foot, you didn't get anything else like a transplant surgery or something like that, and that's why you ended up doing diabetic foot conditions. But there is a huge challenge that we're looking at. And the solution we thought of was a digital podiatry center, which I'm going to talk about it as we go further. And one of the devices, which is my invention called NeuroTouch, a digital foot twin, which is the work in progress, and dynamic self-offloading footwear. Again, in the further slides, you're going to see that, and the wound characterization, for which I think we got the patent, and Amit saw that and invited me to talk here. The other inventions that I have in my name is a telemedicine kit, which is way old, and then warm oxygen therapy. And as Amit mentioned, publishing and patenting all these products has been a part of my journey. So this is a digital podiatry clinic where we do various of these tests, including a foot image, plantar pressure, NeuroTouch, ankle brachial index, and the toe brachial index. And we use the Wound 360 app, which I'm going to show later, for screening a diabetic foot, and then predicting a model, a prognosis model, or a predictive prognosis, where we are talking about when the person will have an ulcer in the 5-year time frame or a 10-year time frame. So These clinics are presently running in 2 locations in Bangalore, which was in one of the government hospitals and in one of the rural hospital that is being there. And this is how the triaging would happen. There would be a low risk and a medium risk and high risk based on the screening that we do. And we do dressings there, or we provide a self-offloading footwear. And if it is a high-risk patient, we refer it to the pediatric clinic. So this is the wound characterization application that we have developed. There has been a problem in terms of various architecture that was being used, and we need to do a tissue identification, wound measurements. We need to identify the color and texture, wound bed recognition, wound edge recognition, and the peri-wound area recognition. Most of the apps that are there in the market today only do the wound bed recognition and the wound measurements, but the rest of it is not being done, which is important to treat a chronic ulcer. So this is the workflow. I don't want to go through the complete workflow that has been there. This is made for a B2B solution, not as a B2C where the patients can use it, but this is where the physicians can use this app or use the AI platform to recognize the wound and treat it accordingly. So this is the raw wound image. You might, if you have a question on what is that yellow dot that is there, probably I can answer that in the Q&A sessions. So the first, the picture is taken with a mobile phone. The wound is recognized, and automatically the area comes in. And this is again one more image of where the area is recognized by an AI app. And here the wound bed and the wound edges are recognized again with an AI app itself. And we get to know, well, how much is the healthy granulation, how much is the pale granulation, hypergranulation, sloughy or necrotic. So where the physician or any clinician treating it can do the needful. We can also suggest what needs to be done as a rule-based protocol that is being developed. Again, the wound bed and the peri-wound area recognitions that we see here, and where the peri-wound area is characterized, whether it is an eczematous or an erythematous or a normal or macerated or calloused wound. So this automatically happens with an AI tool that has been developed. Again, the wound edge, how it is being characterized by a simple photograph that we are seeing. And this is converted into a table like this, where we will know exactly how is the measurements of the wound are progressing or deteriorating. What is the various colors which represents either necrosis or sloughy or being infected, and we exactly know what's happening with the wound. And this is something that will be useful in all our case presentations and case studies that we see. Sorry for the gory images that we are seeing here. And this is the app that we are looking at, where a patient characterization is done, a couple of questions is answered, and the wound image is taken, annotated, and it will be characterized. How is the ipsilateral wound? There is a stenosis. Some of the further questions are asked, and this is the wound bed assessment that would come in, and then there will be a what is the next steps that needs to be taken will come in. So this is, or if the clinician is not satisfied, you can talk to an expert to further understand what needs to be done with this specific ulcer. So what has this led to? So this was the first step, and this is what we got recently. We applied the patent for this 4 years back, and we recently got the patent on this, but we didn't stop here. We started looking at, now that the AI-enabled app is there, what can we take it to? This is something called as a 4D bioprinting, where we take the adipose tissue from the abdomen, 3D print it, and then implant it to the wound bed, which acts as a regenerative stem cell therapy and helps in closing the wound in about 4 to 5 weeks time frame. This is a quick demo where the liposuction is being done. This is the micronization of the adipose tissue that is being done. Sorry, what happened? So I don't know why the video is stopping there. So these are the few of the wounds that were healed by the 4D bioprinting, where we prevented putting an split skin graft or a flap on these kind of wounds, and there was a complete healing in about 4 to 12 weeks that we see here. Other device that was invented by yourself with my team of other engineers is a NeuroTouch device, again, which helps in an AI-based diabetic foot ulceration prediction, which does five tests in one device. Again, this is patented in India, and also we got a FDA approval in US and UK and in China. And we are presently, this is in the market in all these countries. This has a small camera which will take the image of the foot, where it recognizes the calluses that are there in the foot, and then say that, okay, this is the area that might be troublesome, which can cause a future ulcer, which is also linked with our typical monofilament test, vibration perception test, hot and cold perception test, infrared thermometer. So all in one device that has been available and helping in developing predictive models for diabetic foot ulcers. A dynamic self-offloading footwear, where it mechanically offloads the high pressure areas. We know that at 200 kilopascals pressure, the skin of a diabetic foot patient would give away and causing an ulcer. So all of our pressures should be below 200 kilopascals, and in the diabetic foot patients, because of the change in the shape of the feet, the pressures at a particular areas of the foot keeps increasing, can go up to 400 to 900 kilopascals. And this invention, or the midsole device that we are looking at, will offload it. A few of the, this is one more mimicking that. I would skip this. So a few of the tests that a clinical validation that we did across 100 subjects, where we see that a significant amount of pressures are offloaded in various regions of the foot. So from where it was 300, it has come down to around 150 for them. Again, similar on the terms of how it works. The last one that is being worked on, I think the self-offloading footwear, the NeuroTouch device, and the Wound 360 application has all been now tested, and we've been in the market per se. But the digital foot twin is still in the pipeline. As we said, using the DeepWalk data that we have been getting, we would like to kind of mimic the complete foot and then start predicting in terms of what will happen to the bones and the ligaments if the patient continues the similar lifestyle that he is doing, and what would happen if he wears a normal footwear, what would happen if he uses a self-offloading footwear. So these are the things that we are working on in terms of creating a digital foot twin and a predictive model for not only the diabetic foot ulcers, but this will lead to various things in terms of sports injuries, and also forensic podiatry, where just by walking on a mat, a person's attendance can be marked, or we can probably look at what conditions the patient has just by walking on a mat when he's entering the home or entering the office. Various clotos, MTP joint, curvature has always been mimicked in a computed model of a particular patient. So this is a physics informed machine learning that we are looking at, and not just a computation model per se. So the social impact that we are looking at from all these inventions, or the work that we have been doing, is we need to screen the unscreened, provide affordable therapeutic footwear on demand. We need to detect the diabetic foot conditions pretty early on and provide early interventions, reduce incidence of DFU and in mortality, and the reduced mortality that we have been seeing, reduced amputation rates, as I said, in India and globally, we can prevent up to 80% of amputations that we are seeing, and the reduced mortality. My message to each of the doctor or the engineers who have been there is the future of healthcare is about making technology invisible, integrating it seamlessly into empathetic workflows, enabling providers to focus on care delivery instead of mastering technology. With this, I end my talk, and after Dr. Adeep's talk, happy to answer questions.
Thank you. Thank you so much, Dr. Sanjay Sharma, sir, for sharing your journey from the operating rooms to the innovative labs. And your work in the whole AI-powered wound care is not just visionary, it's also really rooted in everyday realities of everyday practices. Thank you so much for sharing. Now we go ahead with our next speaker, Dr. Adeep Sheikh, sir. And there are already a lot of audience questions coming in. We will take all these questions at the end of the session after Dr. Adeep sir's talk. So yes, to introduce Dr. Adeep Sheikh sir, he has Masters in Sports Medicine. He has MBA from an Ivy League college. He's a CXO of Healthify Me. He's founder of Y Health and Project Longevity. He's a chief strategic officer, and he has done his MBA from Cornell NYC, Masters in Sports Medicine, leading metabolic health expert and a research scientist. I welcome you, sir, and we are very eager to hear you talk. Over to you.
Thanks, Aishwarya, for the introduction. And I'm really glad to be here. And it's a really fabulous gratitude to Dr. AI and especially Dr. Amit Kumar. So he's been running a fabulous AI community, which was certainly needed. And that will certainly drive the next gen AI applications to technologies in HCP-led technologies. So I'll not really, dive deeper into what exactly I'm doing or I've built, but more on the lines of how we as doctors can, build an impact and how we can scale the community. I'll just start quickly sharing my screen. Yeah. So primarily, I'll be talking about decoding tech. So decoding tech in healthcare, and supposedly we call it health tech. And I also want to talk more about $1 million weekend. So how exactly you should get started and when is the right time. And obviously, I would also like to hear from other guys, and rightfully, or Dr. Sanjay presented, like it's a process. Like you have to get started from somewhere, but it's all about getting started today. So that's the first principal notion, to get started today from wherever you are. But there's a thesis to it. When to launch, how to launch. It's all about figuring things out. You really need to know everything around building ventures. But the first principle is to know where are your customers. So you need to really spend some good time in researching, looking at the problem statements, and ultimately achieving the product market fit. So I'll also kind of not really throw some finance jargons, but yeah, I think the businesses should be numbers driven, and that's how we go back to building products. So ultimately, who's gonna buy a product today? That's where we come on down to. So I'll just pick a number, like how AI healthcare companies are getting funded, and it's on the rise. So we're looking at almost around like $11 billion being invested in this space, and less than 0.5%, or I would say 4%, is where there are doctor-led companies. But majorly, they're all doctors who are driving these businesses. So that's where that bothers me personally. And that's what we started my whole journey. I started way early with some multiple exits, and I've learned from a lot of mistakes. I've done a lot of mistakes in my whole journey. But yeah, having said that, we really need to look at the numbers, do the research, not just going with the notion. I feel this is the way I should be building business. This is the right market for me. But we should rather go looking at what exactly the customers are looking for, or rather the patients are looking for, and which is the absolute needs. It should be a balance out of both the things. So I've been primarily more in the cardiometabolic space. So we found out the gap, like, wherein there are some direct D2C startups wherein they are giving direct services to the patient, and it's not majorly doctor led at scale. So that's what got me building YHealth. So uh, with the Gen AI, the medical knowledge is just getting better and faster, like day on day. So if you look at the way the knowledge graphs, or you can say the LLM models are getting post-trained on certain database in healthcare. It's a recent one coming from Stanford. And I hope, like, a lot of them must have checked the health bench rubric scores. So even OpenAI had to heavily rely on doctors. But my other question is, why can't doctors really build something like a ChatGPT of health? We really need to deep dive into AI-driven precision healthcare. And by the way, this is one of our reports, like, I helped Fit Insider build it. So this is just taking it from the same report. So we really need to look at the whole cycle of getting into prevention, personalization, building community insights to participate, user engagement, and obviously getting into the prediction. And not missing on the twins, but yeah. So twin has been a little buzzword for a while, but twin certainly helps you stimulate hypothetical case scenarios, which it's hard for us as a doctors to really look deep into it. So we can really build our own virtual extended healthcare clinics. So I just run a quick video, So I would certainly want all our doctors to kind of get hands dirty with building some quick AI solutions. It could be as simple as just going to the Google AI Studio, giving a good, really nailing the prompting, like, of your users' historical data, the current data, and any data they would get from lab reports, or let's say any wearable data. And so basically, this is Google AI Studio. I've just created a prompt around diabetes. I've given a user profile, and it's super easy to build. There are a lot of no-code, low-code options available right from Windsurf. If you have some deep knowledge, and if you can understand JSON language, or even if you don't, you can go for Lovable, VNot, and those kind of solutions. So just having leveraging AI, you can hyper personalize the solution for your end user, and it's as simple as just getting your hands dirty with certain kind of tools. So I think this is the first way to really dig deeper into going and building your own virtual twins. So that's where we can get in the leverage, and obviously moving towards the precision medicine 3.0. I'll be talking about how exactly you can build your own digital clinic. And it's super simple to do that. You can maybe leverage tools like Lovable, v.dev, and you can certainly build a front end with some basic prompting, or you can say white coding the logic. You can have users biomarkers. You can also look at the biological age. You can also create a section, wherein you can interact or talk with your users depending on the flag events, or it might get triggered by your own virtual twin. So these are some solutions which you can build quick and dirty, and we can get started. So these are some starting points. Yes, doctors need to get very leveraged into it. And this talking about one piece of solution, wherein I am seeing a lot of gap, and which is where we as YHealth are working. So we're trying to build a patient twin that stimulates the data with a virtual doctor claim. So we're leveraging a lot of variables like smart rings, smartwatches, the Whoops, the Garmins, and things, CGMs. Then we also built this Snap, a meal, AI describe, and things like that. We also gotten into prediction of glucose curves, virtual CGM, and we have built our own proprietary AI neural engine, which can be related to an AI health coach, and where it can drive a hyper-personalized solutions, which is further monitored by your healthcare practitioner, but not exactly, getting into what why does. but this is just a snippet, like, how and where the technology is headed. It's headed into hyper-personalized solutions, precision medicine 3.0, really looking at this phenotypic levels. I could say the biological side of things, the proteomics, multiomics, which is quite a thing now, and that has to be data-driven. And this is the data you can map for personalized program. So you can think of creating something like a metabolic review program, which is something that can leverage the data. It can come from biovariables. You can have a comprehensive health dashboard, and on top of that, you can add your own thesis, which you can train over the patient data patterns over time. And that what gives you an edge leverage of building a hyper personalized, or you can say a precision medicine 3.0 kind of a solution. Yeah. So this was primarily my side of things, and I think I can maybe we can take it to Q&A. I'm super happy to kind of help other peer doctors to build solutions in real time rather than just giving them snippets. But yeah, super happy to chat with peers.
Yeah, thank you so much, sir, for sharing all that knowledge. One thing I couldn't miss from your talk was how you said that you've made many mistakes and you've learned from them. So, what do you think? Suppose I'm a new doctor who's entering the field of entrepreneurship. What do you think are the most common mistakes that I can commit, which you could guide me on?
Okay, so when you're starting, like you already have a thesis, like it's just something that's gonna work, but you need to test that thesis, and the best way is to kind of check your zone of influence. Or we in our venture space we call it the early true fans. So you really need to talk to your patients, and no surveys. Most of the time, the survey doesn't work. So you need to talk to your customers. Yeah, in this case, those are patients, and are they willing to pay today? Because then if you're trying to do something good even for the community, it has to be scalable. And that's where, the whole notion of building ventures are killed, and, keeping it bootstrapped initially. And with the way how the whole market is saturated, it's quite hard to even raise funds these days. If you're building, we say healthcare is hard in India. Even the top VCs to, the top founders here. And imagine, we as doctors with little limited knowledge on the finance, on the data science, on the tech, we intend to build something, it gets 1,000 times more harder. So we need to be prepared, and always having a community first approach is where we'll get initial traction. And we should always go for the product market fit. And one thesis which I would always suggest someone who's getting started as a doctor to build a business model canvas. Going back to the textbook theory, looking at the key indicators, the key drivers, the revenue streams, and things like that. At the end, if you're building a startup, like, the first thing you need to do is, take care of yourself. Always make sure to have some adequate runway when you're getting into certain kind of things. Or, I started my PPT with saying $1 million weekend. What it means, you do all this stuff, figuring things out in the weekend. And you don't really need to have a product if you really want to build something. Like, you can just build a thesis, talk to some customers, you know, convince them to pay initially as your alpha pool, and then start building the product. So that would be the right approach. So you would know so your thesis gets vetted. So that is something, I've been doing throughout. So even in my Healthify days, like, so we kind of launched the product thinking like, we know the market, but it was absolutely, trashed by the consumers, because we thought it might work, and we didn't do the exercise of really going and talking to the customers. So that is one thing, which really matters a lot. And obviously, always reverse engineering from the numbers, really putting how gonna my numbers list would look like 6 months from now to 1 year, and then reverse engineering into the product. So I might end up spending a lot of money in my product, and eventually I get to know, okay, this market is not as mature to pay me today, or I have some competitors I can charge higher. Even there are a lot of killers, that we get into. So we just need to have the basics right. Getting the initial first pool of customers and then building on top of it.
That was because that was going to be my second question. Like, what do you believe in? Build a product first or build your tribe first?
Build a community first. If you're trying to build something digital, like so Dr. Sanjay certainly has a big leverage because it's just the hardware, it's a proven thesis, it can be approved. But if you're trying to build in software, it's already a gray area. Like it falls in the SAMD, but there are a lot of things you can bypass. So even if you have a patent, there are other players, and customer doesn't know what exactly it impacts. So we need to build a community first approach. And the best example is Twitter. It started from a Facebook community, and then it got to WhatsApp, and then they built a product around it.
I would like to invite Dr. Sanjay sir as well here and pitch in your idea. Like, what do you think should come first, a product or a community?
I would say for surely a community, but I would want to add on to what Dr. Ateeb said. When we are going out in the market and figuring it out what people want, there is a fine difference, which I learned from my experience from 2 cents of what I know, is a need and a want. When I go to a doctor and say, what do you want? And what do we are trying to build this, and he's going to give a list of things that he wants. But if I build all that and go back to him, he would use probably 5 to 10% of the features that are there. And if you go to a second doctor or a third doctor in our need finding, then each one would have a different set of wants. So we need to be very sure in terms of identify or differentiate between the want and the need before we build a product. And that's where most of us in the early stages will get carried away. We would have a human story to it and say that, okay, for my grandmother, something like this happened, or for someone in my known place, something like this happened, and I would want to cure it. But is that solution being acceptable across all the stakeholders, across all the communities? It is not just patients, it is not just doctors that they're building in for, but it would be, there are different stakeholders in the medical domain. It is, we all know that in the medical domain, not majorly in India, but across the world, the user is different and a payer is different, and the decision maker is different. The patient is not the decision maker, their relative might be the decision maker. The payer is an insurance company usually, and we talk only about the patient perspective, but we forget the other stakeholders around. So the community need to have all the stakeholders involved, and we need to have our 2 cents to differentiate between what is actually needed and what is actually a wish list.
Very rightly said. Maybe that's why we call it a need gap and not a want gap.
Yeah.
So there are many audience questions coming in. One, Dr. Ateeb, if you can take this one. How do you ensure clinical relevance and accuracy when training the AI models on diverse metabolic health data sets?
Okay, so first thing, you really need to have a large set of database, and there's a big gap in the EHRs and the EMR system. So you really need to spend a lot of time gathering that data first, and it has to be in thousands, if not the lakhs. That is the first principal thing we need to have, and then really picking the right tools, the right foundational models. So let's say today we see there is Med Gamma, Phoebe, and things like that, or you can go with always the staple Llama 4 models, and then you need to really okay. So now we are trying to switch more towards the MCP. You can create your own databases. You can switch the plug to then centralized MCP servers. Have multiple agents at that level, and then at the very top you can have a decision making, or you can say an evidence scoring guardrail. And so this is one thesis, which we've been working lately. But to really build a very, let's say, that can rank higher on MedHelm, or you can say the Health Bench, we need to post-train that data. So it's, a kind of a whale, which requires, millions of dollars of funding and things like that. But to get an accuracy on an LM model, we really need to fine-tune it and on the right sense. We need to have multiple agents and multiple databases. So that's what has been working for us. And, we are always, and now we're getting into the post-training model. So this is something which has worked for us.
What are the various predictive models that you've been using to do this?
Okay,
to fine-tune the data?
Okay, so what we have done is, I can tell you more in the terms of our product, so we have built a virtual CGM. So, we take your first 14 days data, we track your macros, and we track your habit loops, basically stress leads and other parameters that comes from your variables. We create a baseline. And then you need a queue. When you're getting into the prediction model, you always need a queue in the whole process. Let's say, and our queue comes from the food intake. And that's where we kind of get the glucose peak value. So the intention here to give this example is when you're getting into the prediction model, you still need queuing in subsequent frequencies. Without that, rather we all hearing this terminology like hallucination, it would go this way. And you really need a large pool of data sets. It has to go in lakhs, thousands will certainly not work. And the whole data is fragmented throughout.
Yeah,
so that's where it
definitely.
becomes a challenge.
Yeah. Definitely. That's a big challenge because that's where everything starts, right? The more robust data you have, the better software or the prediction models you can build. I agree. So there is another question for Dr. Sanjay sir. How can AI bridge the wound care gap between the urban and the rural settings?
So that was the key thing. The problem statement was exactly the question that has been there. We at tertiary care centers in Bangalore, where we treat, used to get usually the mistreated ulcers, which are come to us in a stage where amputation was the only way forward, and it has been treated by the physicians, by the other clinicians per se, and at the end of it, when they cannot handle it, they would have just referred it, or the patient would have found something and then come to us. So this was the gap. The way it is being treated in the tier 2, tier 3 cities, or even in the villages, versus the way it has been treated with super specialty podiatric surgeons in the cities. So exactly to bridge this gap, the Wound 360 AI model was designed, where it can characterize the wound and tell the clinician at the rural area on whether this has to be treated at his facility. If we have the certain infrastructure at his facility, he can go ahead and treat there, and what is the methodology that he needs to use in treating there. Or if he doesn't have the facility, can he just refer it up to a higher center, rather than he trying out for next 3 months, and then if it doesn't happen, then referring it up. So we have an algorithmic or a rule-based treatment protocol based on the AI input. So what the AI does is to characterize the wound and tell the clinician that this is the character of the wound, and based on that, there would be an recommendation or a suggestion to the physician that, okay, this is the grade of the wound that has been there, and you might have to put him on a vac, you might have to debride him, you might have to use a foam dressing or a silver dressing, and various permutations and combinations is what would be the recommendation that would give. If he has the facility there, he will go ahead and treat it accordingly. If he doesn't have the facility, we recommend him to refer the patient to a higher center immediately, rather than wasting time on dressing with or treating it with the limited facility that is available at his end.
Exactly. Thank you so much, sir, for answering that question. I have a question for Dr. Adeep, sir. So you've been part of both, like the Ivy League business schools and the Indian health startups. What do you think is that one thing that gets like each ecosystem right? Like what's like when you compare both the Ivy League systems and the Indian healthcare ecosystem?
Okay, so I'll pick two examples with two of the ventures. So one, which is primarily, so I hold 47 patents in longevity molecules, even if you see the NADs and NNNs, and things like that. So that venture has been built out of states. And why I was able to, get so much of, you can say, innovations, or you can say, collaborating with Stanford Medicine and building those products, access to capital in Silicon Valley, or you can say the states. It's so those are real VCs. They gestate for a decade. Like they don't really want you to uh, turn around the money, or it can look, or I would say they don't look at the ROIs right away. So that is one difference which I have seen on that side. And the other being on the Indian side is you really need to kind of you can't build a product without having a doctor in the helm of a triage. That's one. And second, you just can't do, and you can't really build another software application which just does the same thing. So we have kind of spent 3 years in, kind of IPing a product. So right through a front phone camera, I can give you HbA1c, hemoglobin levels and things like that. So, you really need to have your own IP if you want to really build on top of a solution in India. And that's where, the access to capital becomes a little easier, and that gives you more vehicle to kind of deep dive into acquiring users and things like that. So that is one on the business side. But at a patient level, okay, so in India, it's a educational first business. We need to start educating end users, you know even on the doctor's behalf, to really get that penetration. And in the American markets, they're already aware of everything. So I've seen this trend, like, someone coming to me, like, my arm is paining, I think my bicep is hurting, I think Sanjay sir can, tell you more, and you might have spent more time than being there. So the markets are very mature there.
Aishwarya, can I take this also?
Please, sir, go ahead.
So, having invented in India and being selling in US, rather than, so I agree in terms of the patience of the VCs, especially in healthcare. The VCs in the West, the US, in the mature markets, there have more patience rather than the Indian VCs, where they would look at very early returns who have been investing in technology models. And in India, if you want to sell it to a doctor, it's going to be a challenge. It's absolutely a challenge to sell it to a doctor. I might be wrong, but I'm just talking about from my experience.
Sir, I'm so sorry to break you here, but you're absolutely right. And that's the big pharma. You can say, if you really want to spoil someone, you have to bring in the behavioral trend, and what they have been able. So Indian farmers particularly have been successfully able to do that, and that's what has hurted and brought us in the last of the value chain.
Absolutely. So I was coming to exactly the same thing. So we invented NeuroTouch and started selling it to the doctors. For about 3 years, we struggled in terms of, the same story, why I told the need versus want. Everybody said, "Well, this is a great device. We need to have it. It is the boon for the mankind." And, they put us on a pedestal there. And when we started to sell it, we had to do about 50 calls to each doctor to sell one device. So it's a challenge. And the pivoting came in when one of our advisors said, "Why don't you talk to a pharma giant? They will buy it for you and distribute it to amongst doctors." And that's exactly happened. And that's the business model today in India. We have sold more than 1,500 devices to the pharma giants versus about 50 devices to the doctors. And we have been surviving, or we've been successful by selling it to the pharma giants. Vis-a-vis, in US, when we started selling, the only thing that they asked was, "What is your CPT code for this?" Or what is your hospital code for this? If you have a CPT code for this, where we can bill the insurance company for this, then we are going to buy it. So that was the huge difference that we saw while, getting to the market in India versus US.
So you're absolutely right. So even with my product, like why? So I had two biases. I can go direct to the consumer, or I can go to the doctor. So, and also the challenge, uh, So I think it's inherited, in our ecosystem, like, the doctor ecosystem, like, we don't pay for anything.
Yeah.
That's first. So ultimately, pharma chipped in and they helped me onboard at least 500,000 users. But still, I'm trying to create a beta pool because I started this venture. I was happy in D2C. But why B2B? Because, there was certain pool of doctors who were like, okay, there are some D2C growth science companies, kind of taking all the leverage in our systems and we want to build it. So it happened with some sensible doctors, coming and like, okay, let's build a solution wherein we can charge the user more, the patient more with a lot of value-added services rather than just relying on the big pharma to, fit in the bills. So I'm seeing the mind shift, but like so like if you have already tracking the trend and in the States, every pharma is trying to go D2C because the consumer is aware, like, and the way, even in India, like, the people, the end patients are shying away from the banks and, moving more towards generic. I think the whole mindset will, by default factor, gonna change. And it's the right time for all the doctors to, start being our own banyas. I have this thing, I keep telling all my seniors, all my, even my batchmates, we have to be our own banyas, or, we can't stand on farmers anymore, like at least for the next decade.
Absolutely.
I think that's what Doctors AI is also all about. Like the whole initiative needs to be doctor-driven and doctor-led, more than depending on all the coders and the big pharmas, etc. So I'm a resident doctor myself, and like, what advice would you give to the resident doctors who are looking to build some AI solution, but I don't know coding, I don't know much tech. So what would you suggest all our young post-grad resident doctor listeners who want to get into entrepreneurship?
Sorry, I'll take it first, Ateep. And so I didn't know.
Yes, sir, please.
I didn't know any coding or per se. It was just an idea saying that, okay, this can happen through AI, because we have been reading about it and other things. And we started working with engineers to kind of, okay, can we do this? Can we do this? Can we do this? Even today, I don't know coding, but there is some 2 cents of AI knowledge that I got by attending a few courses with Indian Institute of Science and PHFI and other things, so that the engineers cannot take us for a ride, saying that this cannot happen and this is the way it would happen, kind of a thing. So at least we can bounce back saying that, no, this is what you could do. Even though I don't sit on the system and code, but I can talk their language and push back things which they say this cannot happen, or this is the only way it can happen. So much is something that you need to know, and don't use ChatGPT and the LLMs that are there only to revise your theses or your presentations, but there is much more to it, even without knowing the coding, is what I would say.
Very well said. Thank you, sir. Dr. Ateep, your 2 cents.
Absolutely. I think it all starts from a frustration, like, okay, it will take 6 months. इसमें इतना ही time लगता है. And then bugs and things. So it always starts from a frustration. But I always had a thing in coding, like, so I learned all the languages early. I got my hands very early on the Flutter, and probably being in the Google's first AI cohort and, really getting a chance to visit Cupertino and, really interacting with DeepMind. Then I got to know what they were building. So I got my hands on MedFarm, way before then the whole thing started. So I started getting deep into data science, and it looks difficult, but it's quite simple. The only first thesis is, you really need to know all the basics. So there are some good lectures in Stanford CSS, 299 and sort of things, wherein you at least need to know the history, really know how things are built or the architecture. You really don't need to learn coding, because I think we are now in the vibe coding space, so it doesn't make sense to learn coding. But yeah, you need to little override in writing logics. And believe me, if you compare vis-a-vis a doctor and a, it's way smarter than writing logic, creating digital biomarkers. Yeah, but you just need to understand that language. That's it. And it's pretty easy. Like, if you really look at it in the sense, like, okay, what exactly they're doing, how things are edited, what are the brackets and things like that, then you start getting a sense of it. And I think the first thing we all forget is, like, so being doctors, we are already a high IQ individual. Like, it's easy for us to catch up. I think it's just, we need to spend some time onto it. Not just spend some time, but get the hands dirty, trying something, And
Right.
yeah, and for your information, like, so we know about this thing YC Combinator, right? Even if you have a lot of knowledge around tech and coding and things, but YC by default likes things quick and dirty. So it doesn't have to be right the first time, and there is a cycle of iteration.
Right. Very rightly said. Thank you so much, Dr. Sanjay sir and Dr. Ateep sir. Like really a heartfelt thank you to both of you for not just sharing your stories, but reminding us what's all is possible when the clinical insight meets innovation. Your journeys from practice to product, from patient care to the platform building shows us that doctors don't have to wait for change, we can create it. We've seen today even like if a doctor sees a problem clearly, but we also need to understand little basics of AI, and that's what we are doing here at Doctors AI. We are promoting AI literacy, AI education, where we know what works, what fits, where it fits, and know what it can't or can replace. That's what literacy, AI literacy is all about. And thank you for emphasizing on it on this web hour today. Thank you so much. It has been a really great discussion. I appreciate both of you to have taken your time out on such short notice and delivered such insightful and inspiring lectures. Thank you so much. We'll keep the dialogue. We'll keep the dialogue ongoing on our Doctors AI platforms, WhatsApp groups and everything. Thank you so much for your time, Dr. Sanjay sir and Dr. Ateep sir. And thank you so much, Dr. Amit Dey sir, for making this happen. Thank you.
Thank you very much, Dr. Aishwarya. Thank you, Dr. Amit. Pleasure meeting Dr. Ateep.
Yeah. It's a pleasure meeting all of you, sir.
I think Dr. Amit sir is driving, so okay. Yeah. Okay. Thank you. Thank you so much again. I conclude the session of MedAI Web Hour. Thank you.
Thank you, everybody.